Thank you so much for coming. We are getting back to full in person, and I know there are a lot of people on Zoom as well. So thank you so much for coming today. And I will be talking about immune checkpoint inhibition and novel therapies for myelodysplastic syndromes. These are my disclosures, and this is the outline. I'm going to cover 4 areas that have seen a lot of developments in the last few years. The first one is updates in classification, as well as risk stratification and response assessment, MDS, the evolving therapies for lower risk MDS, high risk MDS, and then specifically about the immune checkpoint inhibition efforts that I have been trying to kind of do in these disease areas. So what are myelodysplastic syndromes, neoplasm? You can see that we actually have formally added the name neoplasms finally, because for a long time, myelodysplastic syndromes were thought of as a syndrome or pre-leukemia or a disorder, but they are actually cancers, and this has been formally diagnosed by the WHO. They are basically uncommon, only 4 in 100,000 a year, 20,000 cases of MDS in the US. However, the median age is in the early 70s, and the number of patients with MDS has been increasing because we have more and more cancer survivors. I share many patients with many of you on the solid tumor side because those patients have secondary myelodysplastic syndromes, and those can be among the most challenging patients to treat. And you can see here another fact that emphasizes the malignant nature of MDS. So this is the 5-year survival of patients with MDS in violet, and you can see it's 31%, very close to what you get with AML, which is 25%, but much worse than some of the more common solid tumors, such as breast and lung, when you take all the patients together. Again, further emphasizing the malignant nature of these conditions. And more recently, we also understood that there is a large number of people who go through a process called clonal hematopoiesis of indeterminate potential, or CHIP. And this is a condition that happens in up to 10% of people older than 70. And some of those progress to MDS and some don't. But they are also associated with inflammation and cardiovascular risk and many other syndromic dysfunction across the body. This is why multiple disciplines, including cardiology, have been interested in this. And for that, more and more cancer centers have been interested in establishing clinics for CHIP and CCUS. And here, our newest recruit, Dr. Lourdes Mendez, has taken over this aspect. And I think this is going to become very important in the coming years. The management of MDS, as I'm going to show you in a little bit, has been difficult to get new therapies. And part of this is because of the large heterogeneity of the disease. This is a schema showing the genetic landscape of MDS. And you can see here that there are more than 40 recurrently abnormal somatic mutations that can happen in patients. However, less than 6 of those happen in more than 10% of patients. Therefore, there are many different driver genes, and developing therapies that work across the spectrum for patients with MDS has been quite challenging. Another, I think, challenging feature has been the classification of MDS. And over the years, how do you separate MDS from AML has been a moving target. Historically, a blast count of 30% was used, and then this was changed to 20%. Most recently, last year, and this created a huge difficulty in the field, is the target blast count has been moved to 10%. So now there is this new entity called MDS/AML, which is 10 to 19% blast. And this is causing a lot of confusion for patients, especially that the path reports get released immediately to patients nowadays. So they are being told that you have MDS by one classification and AML by another classification. And to address this issue, we actually have worked with a large number of international colleagues to establish an international consortium of MDS. This is an effort that involves many experts across the world to try to come up with a unified way of classifying the disease. And indeed, we have put together more than 7,000 cases, which by the numbers of MDS is quite large, of highly annotated cases to try to come up with one unified classification. There's another update of this effort that will be presented in ASH in an oral fashion this year, and hopefully the paper will be published soon so that we can have one common way in which we can talk to patients with MDS. After that, what is, I think, important is the risk stratification. Why is that important? Because patients with MDS have variable prognosis. Some patients can live for multiple years, while other patients have prognosis that's almost akin to that of acute leukemia patients, meaning that the prognosis can be less than 6 to 9 months. And therefore, having good risk stratification systems is very important. Historically, you can see in this table 4 of the most commonly used stratification systems. All of them rely on the number of the blasts in the bone marrow, as well as the karyotypic abnormalities and the blood counts. However, none of those were very good, because for a long time, we and others have shown that some of the patients that are called lower risk MDS die quickly, die within 2 years of diagnosis, more than 1/4 of those lower risk MDS patients. And it was clear that these prognostic risk scores are not capturing the whole spectrum of the disease severity. And we also have shown that among patients with therapy-related MDS, which historically have been considered very high-risk disease, some of them do okay, do better than some of the other patients. And that's, again, reflective of the variability on prognosis of those patients. And this is why it's important to apply good risk stratification process for every patient. After all of this, basically, the IPSSM, the molecular IPSS, was finally published after a large international effort in the New England Journal of Evidence. You can see the Bernard et al. Citation. But the short of this is that it incorporated the molecular alterations in the calculation, and that led to a more accurate risk stratification picture. And we have shown in a large analysis of phase 2 and phase 3 trials that we presented last year in ASH that this system does lead to upstaging of patients. You can see in red the high-risk patients by the old scoring system, the IPSS, then the revised IPSS, then most recently the molecular IPSS. And you can see that the number of patients who are being diagnosed now as high-risk disease, because their prognosis is indeed poor, is becoming higher. And therefore, more of those patients are being directed for aggressive treatments. The last area I want to cover before we go to therapeutics is the response criteria. This is actually a very important area because response criteria have been quite problematic in MDS. And I can tell you that it's my belief, and several of my colleagues that the same belief, that it has impeded drug development in MDS. Why is that? Because some of the issues with the response criteria have led to certain medications moving from phase 1 to phase 3 that probably should not have been the case. And this is why we have many phase 3 failures in MDS. So again, using a large international effort over the last 2 years that was coordinated through the International Working Group, we have revised these response criteria, and this consensus proposal for revised International Working Group criteria has been now published, and it started to be implemented in some clinical trials protocols. We have been in discussions with the FDA as well about implementing this in their assessment, and I'm hopeful that this will become a more uniform way of looking at clinical trial to further establish the efficacy of therapeutics in a more consistent fashion. And we are validating this using the Validate database, which will look both at the International Working Group criteria as well as the IPSSM. We actually have this database, again, with 15 different centers. 6 of those presentations are going to be upcoming in ASH. 2 of them are oral presentations by Dr. Tarek Yuan and by our newest recruit, Dr. Jan Beversdorf. So I think this is going to further validate these response criteria as the way to establish them as the way to approve medications in the future. So now moving from classification and response assessment to therapies. And you are looking here at the approved therapies in the top line by the FDA and in the lower line by the EMA. And what you can quickly see compared to many solid tumors is that we don't have many approved therapies. This has been a very frustrating road for drug development in MDS. And in high-risk MDS, for example, we did not have a drug approved in the last 20 years until the year 2020. So I'm going to show you the main therapies that we currently have available and how we are finally breaking through that deadlock of therapeutic evolution. And we are starting, I think, to have better therapies come along. So the traditional approach of treating patients with lower risk MDS depends on symptom control because we cannot currently cure these patients. The only way to cure a patient with MDS with a bone marrow transplant, but bone marrow transplants are usually reserved for patients who have higher risk disease, not lower risk disease. For patients with anemia, the standard treatment would be ESAs, erythropoiesis-stimulating agents. However, those drugs are not active except in less than 1/2 of patients, 40%, and the response lasts less than 12 months. And I'm going to show you how this landscape has changed in the last couple of years. So the first, I think, major improvement was the introduction and final approval of this drug called luspatercept. What is luspatercept? It's a ligand trap. It works on a pathway called transforming growth factor pathway. These ligands suppress erythropoiesis, especially late erythropoiesis. And using this ligand trap has led to restoration of effective erythropoiesis and ultimately improved transfusion independence. This led to transfusion independence in around 40% of patients in the phase 3 Myelodysplastic trial, which was the landmark paper published in the New England Journal of Medicine. And based on this drug was approved. And we have subsequently published additional follow-up from this trial that showed that this drug not only leads to high rates of transfusion independence, but it actually also leads to significant reduction in transfusions for patients who do not become transfusion dependent and lead to hematologic improvements. And this year, the major development in lower risk MDS has been the final publication of the COMMANDS trial, which looked at the activity of luspatercept in the frontline setting. So this is comparing it against erythropoiesis-stimulating agents in patients with ring sideroblast and without ring sideroblast. So this was a primary analysis. This paper is now out in the Lancet journal, showing that patients who receive luspatercept achieve 60% transfusion independence, almost double that what you expect with patients who receive ESA. So clearly a very active drug, and it's moving to the frontline treatment of MDS, which is a fundamental change in how we treat patients with lower risk MDS. We are trying to move this further through 2 other trials. One is the ELEMENT trial, which is a large phase 3 trial that will be looking at patients who are not transfusion dependent. Here we are trying to move the bar higher, and we are trying to prevent patients from even becoming transfusion dependent by treating them at an earlier stage of their anemia. So this trial, which will open at Yale, I think will be very important as a landmark trial in the management of MDS if it's positive, because it would be the first time we get a drug potentially approved for patients who are not yet transfusion dependent. And another phase 3 trial that we are working on with the sponsor basically is looking at the use of the drug at maximal doses, because we currently, many of the patients are not being escalated to the right dose that leads to highest response rate. So I think starting with the higher response, with the higher dose is going to increase the response rate and potentially open the door for more and more patients responding to this drug. And this trial is also going to open at Yale. Another drug that I think generated a lot of interest is imetelstat. This is a first-in-class telomerase inhibitor. So telomerase activity in patients with MDS has been associated with high-risk disease, and inhibition of the telomerase has led to restoration of effective erythropoiesis in a large phase 2 trial. This is a drug that's given intravenously every 4 weeks, and in a phase 2 trial led to 40% transfusion independence. So this was taken to a phase 3 trial. We have presented the data of this paper in ASCO 2023, and the paper is now in Lancet in Press, where patients were randomized to receive imetelstat versus placebo. Again, those are patients who are heavily transfusion dependent with lower risk MDS. And you can see here again that the rate of transfusion dependence was similar to the phase 2 trial with 40% compared to 15%. And importantly, the degree of hemoglobin elevation is actually quite prominent. So the hemoglobin increase was almost 3 grams on average from a hemoglobin of 8 to hemoglobin of 11. So quite active. And the durability is very good. It's around 51 weeks, which by MDS criteria is actually pretty good. So this drug is currently in front of the FDA for consideration of approval. And if it gets approved, it will offer another, I think, very good opportunity for our patients with lower risk MDS to become transfusion free, which is very important. Moving to high risk MDS, this is where we have more of our recent failures, I would say, in development of new therapies. This figure I'm showing you has not really changed in the last almost 20 years. So patients who are candidates for transplant go for transplant, and those who are not, they receive hypomethylating agents. However, we know that hypomethylating agent treatment by itself is not great. The long-term survival, only if you use HMA without going to transplant, is less than 4%. And for that reason, we strongly encourage patients to consider transplant whenever possible, but also try to build upon HMA therapy to improve outcomes. And this is kind of a summary of 3 different real-life studies that we have done that show that the real-life outcomes with HMAs are actually much worse than what you see in clinical trials, with a median survival of only 1 year on average for patients with high-risk MDS. Again, further emphasizing the point for new therapies for patients with high-risk MDS. And we have tried for a very long time, over the last 20 years. Unfortunately, this graveyard of combinations of drugs that were added to hypomethylating agents keep expanding. The latest addition was this drug magrolimab, which works on the CD47 pathway. This is a very, this drug has generated a lot of excitement early on, but unfortunately, a recent press release a couple of months ago showed that phase 3 trial of this drug was negative. We can talk, I guess, in another time once the data is publicly released about the reasons for failure and how we can try to come up out of this system. The good news is that we have other drugs that are more exciting and potentially could lead to approval. One of them is venetoclax. So venetoclax is an oral PCL2 inhibitor. This is already approved for patients with acute myeloid leukemia who are older. The frontline phase 2 trial showed CR responses of around 35% and across the genetic spectrum of MDS. We have published a phase 1b study that shows that adding venetoclax to HMA is actually active in the HMA failure setting, which is a very difficult setting to treat patients in. It leads to responses as well as transfusion independence. But the pivotal phase 3 trial is fully accrued now. It's called Verona. This trial might change the landscape of how high-risk MDS is going to be treated. This is the scheme of the trial that we presented a couple of years ago. This trial is now fully accrued. The results are actually expected by early 2024. And if this trial is positive, it would lead to a new standard of care. Now, moving to immune dysregulation myeloid malignancies, and this is an area where I have personally invested quite a bit of time trying to develop new therapies for both MDS and acute myeloid leukemia. So we know that the most effective treatment for patients with MDS and AML is bone marrow transplant, which is effectively is an immune intervention. We know there is significant dysfunction in the immune system happens in patients with MDS and AML, both at diagnosis, but also during the progression of the disease. There is both quantitative and qualitative abnormalities that happen in the T cells, including the regulatory T cells, but also in the macrophages and the NK cells. And study after study have shown that these increase in frequency as the disease progresses. The question has been always, are these pathogenic? Are they basically mediating the progression and the resistance of AML and MDS? Or are they basically a red herring? They are just a phenomena that comes with the progression of the disease. And the first trial, I think, that generated a lot of interest of immune checkpoint inhibition, which clearly in solid tumors have led to a major revolution, but in blood tumors has not led to the same impact so far. However, the Dana-Farber group published this trial using ipilimumab, which is a CTLA-4 inhibitor approved for multiple solid tumors now. It was a small phase 1 study, but it was done in the post-transplant setting where the drug was given for patients who relapse after transplant. And what they have shown that the drug was tolerated. There was some GVHD, but generally it was well tolerated for the most part. And they were able to achieve 5 responses, 5 complete remissions out of 13 patients, which again was a proof of principle that immune checkpoint inhibition post-transplant does actually work. And this generated a number of trials looking at the drug in MDS and AML. This is one of the trials, one of the early trials that I have worked on actually when I was at Hopkins and later moved it to Yale. It was multi-center. It was in the post-relapse setting for patients with MDS. So this was not after transplant. This was after HMA failure in patients with MDS. And while we have shown that the drug was well tolerated, we could manage the immune-related adverse events effectively, similar to what they do in solid. tumors, the clinical responses were generally very low, and the drug was not clinically active. We did achieve some disease stabilization, but stable disease is always very tricky in MDS to figure out, is it related to the biology of the disease being indolent in some patients, or is it related to the activity of the drug? However, among those patients who had stable disease, we have conducted extensive correlative testing with Leo Losnick at Hopkins, and we have shown that there was an increase in the frequency of ICOS, which is a costimulatory molecule, but this was not basically associated with increase in the peripheral T cell receptor diversity in terms of association with response. And I think trying to find biomarkers for patients has been one of the also challenging areas in immune checkpoint inhibition in MDS. Of course, single-arm trials, as I mentioned, are not very definitive in any kind of activity. Some of those phase 1 trials have shown positive signals, but the definitive way to achieve that would be with a randomized trial. And we worked with Celgene/BMS to develop this trial of randomized trial. This was the only randomized published trial to date of immune checkpoint inhibition, both in MDS and AML. So patients with MDS or AML in 2 separate cohorts, more than 210 patients, were randomized to receive azacitidine or azacitidine with durvalumab. Many of you are probably familiar with this PD-L1 inhibitor, which is approved for multiple solid tumors and has shown overall survival prolongation in several settings. However, again, this was a negative trial. You can see here complete overlap in the overall survival and progression-free survival curves, and no difference in the primary endpoint, which was the overall response rate. So this was disappointing. We tried to understand better why is that the case, why did the drug not lead to improvement? So the first theory is that one common thing we see with MDS trials is that when you add a drug on top of MDS, you lead to less exposure of azacitidine, which is the only drug shown to improve survival. And therefore, maybe adding durvalumab has led to reduced exposure of AZA, and that's why we did not see benefit. But you can see in this analysis in the green bars that the number of cycles between the 2 arms was actually similar, and most patients have received more than 4 cycles. So it doesn't seem like this underlines the lack of therapeutic efficacy. To the right, you can see also that there was similar hypomethylation, which how we think how those drugs, hypomethylating agents, work, and no difference between the 2 arms. So it doesn't seem like there was antagonism there. We also tried to see if there was an increased expression in PD-L2 as a mechanism to bypass the PD-L1 inhibition, and that also was not the case. So none of those mechanisms seem to suggest why the drug did not work. What was actually quite surprising is that when we conducted serial flow cytometric analysis, we did not see T cell expansion in diversity or in quantity by flow cytometry, neither in the bone marrow or in the peripheral blood between the 2 arms. And this was particularly surprising because there has been a prevailing theory that the reason why immune checkpoint inhibition does not work in AML is that once you give it subsequent lines, 3rd, 4th line, that the immune system has been beat up a lot by the chemotherapy. So here we were giving it in the frontline setting, and still it did not lead to immune stimulation. The last thing we tried to do with this trial is to look at subsets of patients, because here you are putting all newcomers together, and maybe certain subsets of patients benefit better. So we tried to look at 2 specific subsets, patients who have TP53 mutations, which have been shown to have a microenvironment in the bone marrow that is more immunosuppressive and might be more amenable to immune checkpoint inhibition based on multiple sources of data, as well as patients who have splicing factor mutations, which Omar Abdul Wahab from Sloan Kettering and others have shown could be more susceptible to immune checkpoint inhibition. However, we also did not see any activity in those patients who have TP53. This analysis was presented by Jan in a couple of years at ASH and is currently under consideration for publication. So we try to think further about how can we overcome this immune checkpoint resistance for patients. And one theory is that myeloid-derived suppressor cells could be mediating resistance. This was based on solid tumors, and we replicated the data Dr. Tik-Kun Kim, who's currently at Vanderbilt, was here at Yale, did very nice preclinical trials that suggested that there could be benefit of combining a drug that targets myeloid-derived suppressor cells, such as entinostat, which is a histone deacetylase inhibitor, with Pimpro or PD-1 inhibitor. And based on these preclinical data, this was translated to a clinical trial, a multi-center phase 1 trial that was conducted in collaboration with the UM1 group under Pat LaRusso, with the theory, again, that adding entinostat would suppress myeloid-derived suppressor cells and therefore allow pembrolizumab to exert its immune checkpoint inhibition. So that the trial has been presented by Jan. I'm not going to go through the results because, again, unfortunately, it was clinically negative. We are currently going through the correlative data to understand what led to the failure of the clinical data. However, I think there are more exciting agents. One of them is sabatolimab. So sabatolimab is a novel immune checkpoint inhibitor. Sabatolimab targets TIM3. So TIM3 is not only expressed on T cells and mediates immune checkpoint inhibition, but it's also expressed on leukemia stem cells and leukemia blasts. And targeting TIM3 in preclinical data has suggested a potential, not only efficacy, but a potential functional mechanism in which it can lead to immune checkpoint inhibition, but also direct targeting of the leukemia stem cells. So the Stimulus MDS1 trial was the first randomized trial with this drug. This trial randomized patients to receive HMA versus HMA with sabatolimab. And the primary endpoint was complete response and progression-free survival. We presented this data in ASH last year. Currently, the manuscript is under review. And while the trial did not meet its endpoint, there was no significant statistically improvement in complete remission or progression-free survival. You can see that there was a late separation in the curve of the progression-free survival and some trend toward improvement with the PFS. So we also sub-analyzed these data, and what we have found is that patients who have lower disease burden seem to benefit more. However, of course, this is ad hoc analysis, exploratory analysis, but what was also exciting is among the patients who achieved response, as you can see in the red, patients who achieved who got the combination seems to have double the duration of response compared to those who have HMA alone, which again suggests that the combination might deepen the response, leading to longer duration of activity. So the Stimulus MDS2 is a large randomized phase 3 trial of sabatolimab plus AZA versus sabatolimab alone. And this trial, again, is fully accrued, more than 530 patients enrolled on this trial. This trial is also expected to report by early 2024. So between venetoclax and sabatolimab, hopefully one of those two at least will be positive and change the landscape of how we treat patients with high-risk MDS. So moving to the AML front, where we have also tried to move some of those concepts forward. So the PLAST AML1 is a randomized phase 2 trial, an IIT that is also running through the UM1 mechanism with Pat LaRusso. Rory has been, Dr. Shalis has been working on this with me, and this trial is actively enrolling. We have more than 40 patients right now, where patients are getting 7+3 versus 7+3 with pembrolizumab. The primary endpoint is MRD negative CR. Another randomized phase 2 trial that we are working through the same mechanism is PLAST AML2. And this trial looks at older patients where the combination is azacitidine with venetoclax plus minus pembrolizumab. This trial is also through the UM1 mechanism. And through both of those trials and in collaboration with CMAC, which is a cancer immunotherapy monitoring group within CTIP, we are conducting an extensive set of correlative studies. We are also collaborating with Dr. Jerry Radic from the Hutch to look at MRD negativity through different more sensitive techniques, including circulating tumor DNA and at the level of the stem cells, and looking at, as I mentioned, at other leukemia-specific T cell activation and a number of other, I think, important studies. Finally, on the same front, we have the PLAST AML3 trial, which is a phase 2 trial looking at combining IDH inhibitors with pembrolizumab. This is based on preclinical data suggesting that patients who have IDH mutations also have an immunosuppressed microenvironment. So Dr. Lourdes Mendes and Dr. Max Stoll at Hutch, who I forgot to put his picture, sorry, are working on this trial, and hopefully this trial is approved by Merck and hopefully is going to open next year. And lastly, on that front, we also have another trial with triplet azacitidine sabatolimab. This is a phase 2 trial which enrolled more than 80 patients. We presented the data last ASH, and only for the safety cohort, the full set of data has not been presented. And I think we have shown extensively that immune checkpoint inhibition, while can be difficult in patients with leukemia, is difficult to administer for multiple reasons. For example, our patients are often have deep thrombocytopenia, so we cannot biopsy them. If a patient has inflammation in their lung, sometimes it's difficult to know, is this a fungal infection or is this pneumonitis? And in solid tumors, it's easy, or not, at least easier, to go and get a biopsy out of the lung. But in our patients, it's very difficult to get biopsies. We're also hesitant to give steroids many times because of fungal infections that are common in our patients. So conducting immune checkpoint inhibition trials in patients with MDS is a bit challenging. However, it can be done, and this is a retrospective analysis that was done by Dr. Shalis in looking at our own data, showing that the number of immune-related adverse events was somewhat similar to what is seen in patients with solid tumors when they get immune checkpoint inhibition. But also importantly, that we are not seeing excess mortality when we use these agents. So I think it's certainly feasible. I think it certainly has a way to kind of move forward. And one of those agents, I have deep confidence, is going to be positive. But I think another important concept that we need to apply is biomarker selection of patients, because currently we are enrolling all newcomers regardless of their susceptibility to immune checkpoint inhibition. And I keep making the analogy of like trying to treat patients with IDH or all patients with an IDH inhibitor, when you only should treat the ones with the IDH1 mutation, or the same thing with the EGFR. So we really should select patients who are more likely to respond to the specific pathway. This is an example of, I think, a nice effort looking at an immune effector signature to try to define subset of patients. This is clearly retrospective, but I think this is what should be applied in clinical trials in a prospective fashion, so we can select patients who are more likely to respond. So at the end, I'd like to thank our colleagues in the leukemia and myeloid malignancy program, including our wonderful NPs and the fellows and mentors and collaborators. All of them have been working with us, but also importantly, our clinical research team, who has been fundamental to all those clinical trials that I've just shown you, and have been extremely productive even during COVID and all the staffing shortages that we had over the years. And at the end, I'd like to thank all the organizations that helped fund my research, and all the collaborators, and happy to take any questions.
Great talk, and let me apologize for not being here today. I realized I was supposed to be.
No worries.
But I heard you again well on your own. It's a pretty impressive body of work that both are seeing over these past few years. What do we know about, and I apologize if you mentioned this when I wasn't here, but is there any fundamental difference in MDS in younger individuals than those who are, more typically MDS age, so the occasional 40 or 50-year-old person who see it as opposed to 70 or 80-year-old?
Yeah, this is actually a very important question. So the majority of MDS patients are older than 65. Around 85% of patients are older than 65. We do see MDS in younger patients, but generally it tend to be two big areas. One of them is previous exposure to chemotherapy or radiation in the context of solid tumors. Usually breast cancer actually is one common setting where we see patients who have received radiation or chemo and have secondary cancer. But the second big area is genomic predisposition. So there are a number of patients who have, for example, underlying Fanconi's anemia or plastic anemia or some kind of hereditary predisposition. The number of those predisposition genes actually has been increasing significantly, or we are discovering more and more of them, and it's quite fascinating. For example, there is one called DDX41 that we did not know about until a few years ago, and it turned out that 10% of patients with AML and MDS have that, and those are, I think, important because they underlie different clinical behavior. Those patients, for example, tend to be more indolent. I have a 96-year-old patient with AML who has DDX41 germline, and it's just mind-boggling to me that you think that someone carried this mutation until she was 95 to develop finally AML. So those tend to happen in older patients. There are other ones that tend to happen at a younger age, but I think the biggest message usually I usually say regarding younger patients with MDS is you have to look for other things, because there are many things that mimic MDS. And you want to make sure what you are dealing with is indeed MDS, because the treatment is different. Yes. Yeah, this is a very good question. And actually, this has always come up in our discussions with, with IRBs and regulators. And there's actually a large chunk of evidence based on, as I mentioned, the problems that most of the trials that we have done in the field have been single-arm trials. So most of what we have right now is anecdotal experience. We are not seeing overall, if you look at the entirety of data, we are not seeing an increased incidence of GVHD that is of high severity. However, we have never had a randomized trial that would look at this in both arms. And this is why I think our two last trials are going to be very important, because we have two arms and patients from both arms are going to transplant. And I think this is going to give us a good sense of that. The other argument I always say is that while there could be a potential that you could increase GVHD, there's also a potential that you could actually increase GVL, right? So because the way GVL is the graft versus leukemia effect, and this is how we think transplant can work. So I think it's always a risk benefit, and I don't think you can answer that without a randomized data. This is something we are certainly keeping a very close eye on in our different trials, and the regulators have been also kind of keeping a close eye on this. And I have to say, in our practice, we usually try to say stop the immune checkpoint inhibitor, like in the last 6 weeks before transplant, 6 to 8 weeks, ideally, just because of that theoretical concern. I would say at the end is that immune checkpoint inhibitors are approved in subsets of lymphoma, and in that setting, like Hodgkin disease, and generally they have not seen that issue as much. So I guess we'll have to wait and see for AML and MDS. Yes.
Does anybody actually try to look at specific
Yeah, this is a great question. And part of why I did not divulge and go too much into this is that this methylation business has been, I think, one of the most challenging aspects of, Steve Gore, when he used to be here, he used to hate calling these hypomethylating agents, because we are not even 100% sure that this is how they actually work. He always liked to call them DNMT3 inhibitors. I guess the big answer is that in those trials that I presented, they did not do site-specific methylation, but we still don't fully understand what, because you are seeing a mix of hypermethylation, hypomethylation, depending on where you are looking within the genome. And until now, we don't fully understand the mechanism of action of these drugs. I did not go into this because of the nature of the audience here, but I think one of the biggest challenges in my own view about why we could not go beyond HMAs is that we are stuck with this schedule that is FDA approved, 7 days of azacitidine in every single trial that we have. And this is a myelosuppressive combination, and trying to add things to it has been quite challenging. But currently, it's not considered ethical to randomize, without including the 7 days of HMA, because it's the only drug that has been shown to improve over survival. But you're right. I mean, there could be there could be agents that could antagonize that methylation, or it could be the other way around, where this methylation is negatively impacting. So that has been a big, I think, problem. Natalia?
A couple of ongoing studies that pembrolizumab together with either high-dose 7-3 therapy or SSID combination. And we know that those therapies result in quite profound immune suppression, and not only they become shrinking, but they're also quite lymphopenic when you have like probably 0.1. So does it make sense to give them concurrently? I mean, you're trying to mount some lymphocytic response at the same time, completely suppressing their hematopoiesis. So does it make sense to give them concurrently, or would you have a more clever way where you perhaps chemoablate the marrow, allow them to recover, have some immunoreconstitution, and then give a checkpoint?
Yeah. So there are people working on concepts like this where they are giving it around the time of immune reconstitution. As you mentioned, I think 2 points on this front is that they actually have combined in solid tumors. They have multiple, and Barbara and the others know more about this, like solid tumors where you are giving chemo with immune therapy, and it seems like it has worked. But their drugs are not as lymphodepleting as ours. But the other thing we actually have tried to do in these trials, I did not go into this into detail, is that we moved the initiation of the immune checkpoint inhibition to day 8. So rather than waiting until day 21 when, all the cells have died. So around day 8, the idea of doing it early is similar to that this is when you have all the antigens being, from the dying cells coming out and trying to activate the lymphocytes at that point. But you're right. I mean, this is another, I think, big challenge of what is the exact time to use these drugs. Has been somewhat kind of frustrating, I have to say, with both PD-1, PD-L1 so far, and because multiple trials have been negative. So it might be that none of those pathways are, what really is important in AML and MDS, and maybe this sabatolimab that I just showed, or some other, there are other I did not go into this as well in detail, but there are LAG3, there are LILRP4, there are a number of other immune checkpoint pathways that are also being tested in MDS and AML. Yes. TIM3 without the PD-1. Yeah, so I did not go through the solid tumor literature with TIM3, but they actually had a big trial combining TIM3 and PD-1, and that has not led to clinical improvement in solid tumors. So the development has been largely focused on the MDS space. They have the company has sponsored trials where they are combining different immune checkpoint inhibitors and actually sabatolimab with other drugs. So those, I think, could give an idea. But from a regulatory path, you, as I was saying a little bit earlier, is you have to combine with HMA to kind of get your first approval. And then I think, Kantarjian, Hagop Kantarjian always said, like, the real research starts once a drug is approved. Like, you really need to get like something, like once it's approved, I think you can do all kinds of concepts, but the initial focus is always on trying to kind of get the trial that leads to approval. And then you can do all these kind of bigger concepts. You can do them now in a small phase 1 study, but not in a large setting. Yes, Tor. Yeah, again, I think this is a very good question. Clearly, the post-transplant setting is a very important development area because most of our patients, unfortunately, despite transplant, they relapse. So I think with the ipilimumab, the trial, the New England Journal paper I showed you, people have had a very tough time replicating these. I would say outside of occasional responses. So most people are not using ipilimumab of kind of label to give it. And most of those responses, by the way, happened in the extramedullary relapses like skin disease. And probably that speaks to different microenvironment between the bone marrow, between the extramedullary versus the bone marrow relapse. In terms of your other question specific about the TIM3, there's actually a trial giving TIM3 inhibitor post-transplant. I didn't go into this one, but this one is ongoing, and I believe there could be presentations in the near future about this. I'm not involved in it.
That's good happening.
Yeah. No, I think again, like, I think it's like figuring out like the right sitting. Yes. Sorry, could you rephrase that?
Is there any evidence that prevents basically the development of an MBBS or weighted MBBS or AML? Just thinking of like ways to sort of look at that rather than co-treating with like, hypomethylating agent.
Yeah, I think inhibiting development of MDS, this is actually an area that is getting more attention now because of what I showed at the beginning, like this CHIP/CCUS spectrum where clonal hematopoiesis, we are seeing some of this actually in solid tumors. For example, a breast cancer patient under, underlying more and more people are doing these next-gen sequencing, and then the patient turned out to have TP53 mutation CHIP, like the blood counts are completely normal, but she has TP53 mutation. And one of the increasing questions that are being asked, like, the oncologists are afraid to give chemotherapy because that TP53 clone could expand and lead to MDS or AML. So I would say this is an evolving area. Currently, we don't think immune checkpoint inhibition would work. Most of the trials that are looking at agents are looking at things that are very non-toxic, let me put it this way, because those are patients with good counts generally and normal bone marrow. So there are trials of vitamin C and inflammation, anti-inflammatory agents, etc. However, those drugs can be given together. One of the things actually we benefited from doing these trials is that I have a number of patients I share with our colleagues here that need some, that need immune checkpoint inhibition. I have multiple patients, including with Barbara, where they are on some kind of immune checkpoint inhibitor and they have MDS now, and I need to give them azacitidine because they have MDS. And we have been doing this in a number of patients, and for the most part, it's pretty safe. So this in the past used to be a horrendous situation. It's still a horrendous situation. You have two active tumors, MDS and a solid tumor, but many of those patients used to get only supportive care and nothing else. But now we, for the most part, because immune checkpoint inhibitors generally will not lower your blood count, so they are able to give them even with patients with MDS. And I'm able to treat the patient with azacitidine because it does not worsen the immunosuppression. You can give it safely. But again, I think how to prevent clonal evolution is an important area as well. Okay, sure. Thank you so much. My email, if anybody has any questions.